Now let's turn to the second major subset of leukemias. We'll move from acute leukemia into chronic leukemia. And I will start with chronic lymphoid leukemia. This is the most common leukemia in many societies. Interestingly, not all societies, because there seems to be a genetic predisposition to CLL. It's more common in those of Caucasian and Asian origin. CLL develops from the accumulation of a clone of B cells, which you can see on the blood film there, in the bone marrow, in the blood, and in the lymph nodes. On that blood film, you'll see many lymphocytes. You also see many purple smears, and indeed those cells are lymphocytes which have undergone destruction during the preparation of the blood film. Smear cells, they're a characteristic feature of CLL. Now, the B cells in CLL are very interesting. They have a number of unusual proteins on their surface, unusual for a B cell. I've put two there, CD5 and CD23. And it's the presence of those proteins that we look for when we're making a diagnosis of CLL in a patient who has too many lymphocytes within their blood. Now, CLL is quite slowly progressive. It develops over many years. And now, around 90% of patients are diagnosed with CLL simply because they've had blood taken for another reason. They may go for a health check, or they may go to their doctor saying they don't feel quite so well, or a bit dizzy, or whatever it is. A blood test is done, and we notice that there are too many lymphocytes. So it can be what we call an indolent disease, slowly progressive and not needing any treatment. Indeed, treatment is generally only started when the patient needs it. We call this a watch and wait policy. So when do patients need treatment? Well, if they develop anemia, when the CLL cells crowd out the normal cells in the bone marrow and lead to anemia. Or perhaps when the lymph nodes in the neck swell up and cause problems, or the spleen, which can also be involved. So it may seem unusual that we make the diagnosis of leukemia, but don't treat it. But certainly results from several years ago showed that if one treats too early, you can actually have a worse outcome than watching and waiting. What about the treatment of this condition? Well, over 30 years, doctors have been studying different combinations of treatment for CLL, and at the current time, a combination of chemotherapy with injection of an antibody targeted against the B cells through CD20 is the standard treatment. So younger patients would get CD20 specific antibody with more intensive chemotherapy, and older patients would get an antibody with perhaps less intensive chemotherapy. And those are effective in the majority of patients, although they're never in themselves curative. The disease always has the risk of coming back. And these combinations of chemotherapy and antibody are usually given for around 4 to 6 courses, perhaps every month, if possible. And the patient may well obtain a remission for several years before they need treatment again. But in fact, in CLL, as in many areas of hematology, there's been some interesting new developments. And tablets have recently been developed that specifically target B-cell receptor signaling that are very effective in CLL. There are 2 major pathways that we can inhibit, mentioned on the slide. BTK, the Bruton tyrosine kinase, and PI3K delta, PI3 kinase delta subunit. These are 2 proteins which are involved in signaling when a B cell sees its antigen through the immunoglobulin on the cell surface, and they send survival signals and proliferative signals to the tumour cell. And tablets which block those signalling pathways lead to the death of the CLL tumour cells. Now, these have only been around for 2 or 3 years, but they may well come to represent the new standard of care in chronic lymphocytic leukemia. And now drug studies are being designed and started which compare chemotherapy with oral medication. Finally, our fourth subset of leukemia, chronic myeloid leukemia. This is a relatively rare disorder, but is seen in people of all ages. And it's remarkable because we know so much about its etiology, and it led to the introduction of a new treatment that has changed our approach to cancer. In many cases, it's caused by a translocation. This was the first translocation to be identified in cancer, called the Philadelphia chromosome, between chromosomes 9 and 22. Just look at that cartoon on the right and you'll see those pink chromosomes. On the left of those pink diagrams, you will see the normal chromosome 9, and below it, the normal chromosome 22. But if those break at ABL and BCR, they can swap their genetic material and lead to those pink chromosomes on the right, 9q plus, 22q minus. Now, what's fascinating about this translocation is that it leads to the formation of a new protein, a fusion protein. That's shown in the top right. BCR and ABL come together to form a new fusion protein only present within the tumour cells. As you'll see on the right-hand side of the diagram, this protein encodes an enzyme which has tyrosine kinase activity. And this tyrosine kinase activity is overactive within the tumour cells. And through a range of mechanisms, that leads to proliferation of this myeloid cell and generation of the leukemia. And as you'll see, it drives the bone marrow to excess proliferation of the myeloid compartment. The clinical features of CML reflect that myeloid proliferation. Let's look down the left-hand side first of all. Splenomegaly. Often you see a very large spleen under the left-hand side of the ribs in patients with CML. Fever, sweats, and indeed gout, because the patient is making so many cells, and also many of these cells are dying, and gout, interestingly, is precipitated by the formation of uric acid from DNA of cells that are being broken down. Let's look now on the right-hand side. You'll see on the right the particular blood film of a patient with chronic myeloid leukemia. Lots of neutrophils, but also earlier, more primitive cells that we should not see in the blood. Promyelocytes and myelocytes. And in those two tubes, we see the startling feature of CML that we see in some patients. Very, very high numbers of leukemic cells. Just let me explain. On the left-hand side of those two tubes, you see normal blood. It's been placed in the centrifuge. At the bottom are the red cells. At the top is the plasma. And in between those two, there would normally be a very thin layer of white cells, sometimes known as the buffy coat. Whereas in the right-hand tube, you can see that enormous white area. That's the huge buffy coat of the malignant white cells within the blood of this patient. So if you ever wanted to see an example of how leukemia really does mean white blood, that is a typical picture. Now, the treatment of chronic myeloid leukemia is one of the most fascinating areas of medicine. Imatinib is a drug that was designed specifically to treat chronic myeloid leukemia, and it can specifically block the BCR-ABL protein. You can already see how exciting that is because that fusion protein is only in the tumour cells. It's exactly the sort of drug that we've been looking for in cancer, specifically affecting the tumour cells as opposed to chemotherapy. It's highly effective, and simple oral medication can control the disease in most cases. Now, it's true that the disease can get resistant in some cases, or the patient might perhaps be intolerant of imatinib. But there's now several new drugs which also inhibit BCR-ABL in different ways. And indeed, there's some evidence that they may be more effective than imatinib as a first-line therapy. So there are many trials now seeing if these different drugs are effective at different stages and to bring about a more rapid and complete control of CML. But the treatment of this disease has been transformed. Treatment is now monitored by looking at the percentage of the BCR-ABL messenger RNA in the blood. And so we'll see patients in the clinic perhaps every 3 months, and we'll see how rapidly we're killing off the tumour with the tablet combination. And if it's not quickly enough, we will switch to another agent which is more effective. The success of imatinib has changed the general approach to the treatment of cancer. In many types of cancer now, even the common sorts, lung cancer, breast cancer, we're starting to look away from the old-fashioned chemotherapy, which affects many rapidly dividing cells. And we're looking into the genome of the tumour cell, finding the specific mutation that caused that cancer, and looking for a tablet that can specifically block that. And that's how cancer will be treated in the 21st century. So in summary, leukemia can be classified into 4 different subtypes. Now, each of these 4 is very, very different, and you need a very thorough diagnostic approach to make the right diagnosis of the subtype. And I hope that you've seen and enjoyed from this talk that these leukemias are treated by a variety of therapies, chemotherapy, antibodies, and drugs that inhibit signaling pathways. And as is often the case in hematology, the development of these drugs has led to improvements in many areas of medicine. Let me now focus on each of these leukemias individually, and we will start with acute lymphoblastic leukemia. This is the most common type of malignant disease in children, but can also develop in adults. If you look on the right-hand side here, we're showing the incidence rate per 100,000 population according to the age at diagnosis on the x-axis. And you'll see the peak in much younger children. But you'll also see that all populations at any age have a risk of developing acute lymphoblastic leukemia. Unfortunately, the older that one gets, the more challenging it is to achieve a cure for this disease. Now, if we look on the left-hand side of the slide and work through those points, you'll see that in children, it's thought, strongly believed now, that the first mutation causing this leukemia starts in utero, before the child has even been born. This is fascinating for a number of reasons, because it means that we have to be very cautious and thoughtful about the health of a pregnant woman and risk factors that she may be exposed to before even childbirth. How on earth do we know this? How has this conclusion been arisen? Well, occasionally identical twins are born, and one of the twins may develop acute lymphoblastic leukemia. And unfortunately, the second twin also has an increased risk. And when scientists have looked at the leukemia that develops within these twins, they can see that they have developed from the same cell that was present before the twins were born and was shared in the placental circulation. And so that lesson from rare cases of identical twins is now thought really to apply to all cases. But it needs more than one mutation for the tumour to develop, and so something during early childhood leads to more genetic damage and the development of the frank leukemia. Now, when leukemia develops, it tends to present with swollen lymph nodes within the neck, perhaps in the groin, and also the clinical features of bone marrow failure. And I want to emphasize that bone marrow failure is a clinical feature of all acute leukemias. What does it mean? Well, it means that because the acute leukemia cells crowd out the normal bone marrow function, normal blood cells are not made. That means that the patient can get anemic, lack of red cells, so they're tired and lethargic. It means that they're not making white cells, so they're prone to infections. And finally, they're not making platelets and can have bruising or bleeding. A typical feature is small bruises on the legs, so-called purpura, and that's often seen in children who present with acute leukemia. Now, the diagnosis of acute lymphoblastic leukemia is made by a number of different tests. Obviously, history, examination, but then the blood film, immunophenotyping to define the protein expression on the tumour cells, and also, and very importantly these days, genetic analysis of the tumour cell to see which specific genes have become damaged. Here, we've got some of the typical genetic changes that you see in acute lymphoblastic leukemia. There's too many for us to work through during the lecture, but I will pick out some of the most important features. And on the right, you can see the prognostic significance. So as well as telling the type of genes and chromosomes that are damaged and defining acute lymphoblastic leukemia, we can also give a prognosis to that patient as to their likely outcome. So if you look down the left-hand side of that table where it says abnormality, let's look first at numerical change. This is a change in the number of chromosomes within the tumour cell. So remember that all of the cells in your body, perhaps 10 to the power of 14 or 10 to the power of 15 cells in your body, they've all got 23 pairs of chromosomes. But if the number of chromosomes in a cell increases, that's called hyperdiploidy. And you'll see there, if the tumour cell in ALL, acute lymphoblastic leukemia, has high hyperdiploidy, well over 50 chromosomes, that's a good feature, and those patients do well. Whereas if we go down slightly to hypodiploidy, a reduction in the number of chromosomes, that's a poor prognostic sign. So just counting the number of chromosomes within a tumour cell already gives you some prognostic information as to the outcome of the leukemia. But the other feature about the genetics is the structural abnormality, which specific genes are affected in the tumour, and also which translocations are present. They're also very important in prognosis. Now, I introduced a new word there, translocation. What's that? Well, as a translocation, what it is, as we'll see later with chronic myeloid leukemia, the classic example of a translocation, two chromosomes break and they join together. You'll see an example there, the Philadelphia chromosome, which brings together chromosomes 9, 10, and 22 to make the BCR-ABL protein. That's definitive of chronic myeloid leukemia, but it's also seen in some patients with acute lymphoblastic leukemia. And as you'll see, that's a poor prognostic sign in acute lymphoblastic leukemia. But just below that, you will see the T1221. the joining of chromosomes 12 and 21, and the genes there are the TEL-AML1 genes coming together. That's actually a good prognosis, and you'll see that patients with that translocation can look forward to a better outcome after treatment. So you can see how we're starting to get more and more information about the types of genes that lead to acute lymphoblastic leukemia and how they define the clinical outcome. The treatment of acute lymphoblastic leukemia is getting better, but it's really very complex, and it involves blocks of chemotherapy given for even 2 or 3 years. The initial chemotherapy is very important, and it must be given quite quickly. It seeks to kill off the great majority of tumour cells within the patient and achieve a normal blood count. We call this remission induction. We've induced a remission in the patient. The blood count is recovered. Now, this is very effective in most people with acute leukemia. The drugs that we have can often achieve a remission. But that's not enough to cure the tumour because there are many, many tumour cells remaining within the body. And therefore, we have to move to further courses of intensive chemotherapy to remove more and more of the remaining tumour cells. We call this consolidation therapy, and it's given as intensive blocks of combination chemotherapy. Finally, less intensive treatment in the form of tablets or injections can be given for 1 to 2 years as a maintenance therapy. Quite an unusual form of cancer therapy, but one that's been proven to be very effective in acute lymphoblastic leukemia. Now, the types of drugs that we use for treating this disease are really very diverse, and it's interesting to spend a few minutes talking about the nature of these drugs. As you'll see, there are a few examples here. Steroids, which of course are used very widely in medicine in a range of indications, are very effective. They're very good at killing off lymphocytes. Lymphoblasts, of course, are the tumour cell within this disease. That's probably why steroids are so good for treating autoimmune conditions and inflammation through this activity. Vincristine is a very important drug derived from plant material which affects the microtubules within a cell. And it's a very good drug against lymphoid diseases. Unfortunately, it can be quite toxic to nerves. And one of the problems with vincristine is that sometimes patients get numbness or tingling within peripheral nerves. Daunorubicin is an important chemotherapy agent which acts to stop DNA being able to be unwound and replicated effectively. Sparaginase is a very interesting drug because it's a natural enzyme that depletes asparagine, an amino acid. And the reason that it's useful in acute lymphoblastic leukemia is that the leukemia cells need a lot of asparagine to continue to divide. And so effectively, this treatment is depriving them within their microenvironment of enough essential amino acid to reproduce the cell and divide. It's a highly effective therapy. Some more drugs here used in acute lymphoblastic leukemia. Cytosine arabinoside, often known as Ara-C. It's an analogue of cytosine, which is used as a building block for making DNA. And this is a very, very effective agent in acute leukemia. As we'll see soon, this is the key drug used in acute myeloid leukemia as well. Now, one feature of acute lymphoblastic leukemia that has been noted over the last 30 years is that patients often have a tendency to have a relapse of the disease within the central nervous system. It seems that these tumour cells can move to the central nervous system and need special treatment to eradicate the disease in that environment. There are two major approaches. One is intrathecal chemotherapy. That means chemotherapy that is given into the cerebrospinal fluid directly. Another is to use high doses of intravenous chemotherapy of drugs such as methotrexate, which get into the central nervous system and can help to kill off the leukemia cells. Radiotherapy of the brain and spinal cord can also be used, but where possible we try to avoid that because of potential damage to the CNS from using radiotherapy in the long term. Now, the outcomes of acute lymphoblastic leukemia, after all this treatment has been given, are really quite good. The great majority of children with acute lymphoblastic leukemia can expect to achieve a long-term cure. Now, some children do relapse after the chemotherapy, which of course is terribly disheartening after everything they've been through. And what doctors will probably try to do there is to give further chemotherapy or a bone marrow transplant in which the patient is given chemotherapy and then stem cells are taken from the blood and bone marrow of another person, matched for the right tissue type, and given in to the patient. And bone marrow transplantation is an effective treatment for ALL, although it does have side effects. If we take everybody together, around 85% of children can expect a long-term cure through these treatments. And that number is increasing every few years as new reagents and new combinations of treatment are brought into therapy. But unfortunately, in adults, the disease outcome is not as good, particularly as people get older. This is due to the type of genetic damage that we see within the tumour cells with age, and also the ability of patients to tolerate the high doses of chemotherapy that are needed to eradicate this disease. Let's now move to the second major subtype of leukemia, acute myeloid leukemia. On the right, I've got a couple of slides to show you. On the top, you will see those blast cells of acute myeloid leukemia, 4 of them together within the blood. And below, there's a clinical picture of a patient with acute myeloid leukemia. And I hope that you can notice in this case the gum hypertrophy, particularly below the teeth. That is due to acute myeloid leukemia cells, particularly monocytic cells that have this characteristic. They are actually accumulating within the gum and causing hypertrophy and tissue expansion. So, acute myeloid leukemia is seen in people of all ages. It can just arise on its own, or it may develop from pre-malignant conditions such as myelodysplasia or myeloproliferative disease. I'll be discussing those disorders in another lecture. The net outcome is that we see an accumulation of primitive myeloblasts. And just as for acute lymphoid leukemia, genetic analysis is very important in classifying a subset of AML that we are dealing with. That's seen on this slide here. So the subtypes of AML are very, very complex. A primary AML is one that arises as a new disease on its own, whereas the disorder may be secondary to myelodysplasia or previous chemotherapy, perhaps somebody who had treatment for breast cancer 5 or 10 years ago. And in this situation, the AML is more challenging to treat. And just as with ALL, acute lymphoblastic leukemia, the genetic analysis will classify the AML into different risk groups. Some patients have a good risk outlook, some are standard, and some are poor. And as well as just being able to say to the patient or the doctor that we can predict outcome, this information is more useful than that because it can make a decision as to which treatment is used for the individual patient. Now, the figure on the right shows how these different types of acute myeloid leukemia are seen in patients at different age. On the x-axis, we see patient age from 0 to 14 to 60 and over. And on the y-axis, the percentage type of disease. And I would really only pick out two major factors from that chart. In grey, secondary AML. And you will see that as patients get older, the relative frequency of secondary AML increases. And that makes sense. Patients have had more time to accumulate damage or to have had previous chemotherapy. And secondly, the type of AML associated with good risk goes down as patients get older. So you can see already that younger patients have a better outlook for their AML treatment. And how are we going to treat AML? Well, again, this is a very intensive chemotherapy, similar in principle to the way that we treat acute lymphoblastic leukemia. So that induction chemotherapy that we give, where patients after diagnosis tend to come into hospital and be given intravenous chemotherapy, here is given with Ara-C, cytosine arabinoside, and daunorubicin. And that combination, given for a few days, is really highly effective in killing off the vast majority of acute myeloid leukemia cells, and then the patient can recover after 2 or 3 weeks into a normal blood count. Now that's reassuring, and the patient is, for the short term, relatively safe at that point. However, as with ALL, that is not a curative approach. We need to consolidate that with several courses of intensive chemotherapy. These are again given often as intravenous drugs into the vein. The patient may come into hospital for them, or they may stay at home and just come in for daily injections. The risk here is that the patient is rendered really quite prone to infections, and that's a major challenge. So it's a challenging treatment, but at the end of it, many patients are indeed definitively cured. Now at the bottom there, I've mentioned stem cell transplantation, and this may be used for patients with acute myeloid leukemia. It's particularly used for people with high-risk disease because we know that chemotherapy is not very good in this situation. And it's also very effective in patients where the disease relapses. That means that a patient has undergone all of the chemotherapy and then perhaps a few months or a few years later, the disease returns. We know that in that situation, giving the same chemotherapy again is unlikely to get us a cure, whereas a stem cell transplant can be highly effective in this state. Just a few words about stem cell transplantation. It used to be known, you may know it as bone marrow transplantation. The name changed because we now get most of our donor stem cells from the blood of the donor, rather than having to go to the bone marrow. And the important thing to remember about stem cell transplantation in acute leukemia is that the stem cells come from another person. It's what we term allogeneic stem cell transplantation. We used to do stem cells from the patient's own blood and bone marrow, which had been stored prior to delivery after chemotherapy. But that's not so effective. And the final point, which is very interesting, is when we do a stem cell transplant from another person, those cells that we put in undergo a very interesting immune effect where the stem cells attack the leukemia within the patient. We call that a graft versus leukemia effect. and it's highly effective in mediating the cure that arises from a stem cell transplant. Now then, there is one subset of acute myeloid leukemia that needs to be treated very differently. And that is this disorder that you can see on the slide on the right, acute promyelocytic leukemia. And this is a tumour of promyelocytes. And as you'll see, they are very, very granular cells. Now, APML, acute promyelocytic leukemia, is caused by a specific translocation in most cases, a translocation between chromosomes 15 and 17. And the major clinical concern of this disease within the first few days is a very high incidence of a disorder called disseminated intravascular coagulation, DIC, severe bleeding tendency, and unfortunately, this can be fatal within the first few days of treatment or at presentation, before the chemotherapy has had time to work. And so regular clotting tests and administration of products such as fresh frozen plasma is a critical component of the therapy of patients with acute promyelocytic leukemia. Now, there's a very interesting story about this disease. The T15-17 translocation involves the retinoic acid receptor. And therefore, doctors tried all-trans retinoic acid, or ATRA, as a therapy, simple oral tablet. And indeed, it's a highly effective therapy which should be given immediately a patient is diagnosed with this disorder. On its own, it doesn't seem to be curative in a high number of patients, so it's often combined with chemotherapy, but usually a relatively milder chemotherapy than is given for other forms of AML. Would you believe arsenic is now also being used for the treatment of acute promyelocytic leukemia and is proving highly effective. So it's really a very fascinating subtype of acute myeloid leukemia. The outcome of AML as a whole is improving but remains challenging. The supportive care of patients with acute leukemia has been critical in achieving the good outcomes that we can now obtain. This involves the use of antibiotics, blood product transfusions, and indwelling catheters. You'll see on the right a classic chest X-ray, and you'll see the heart, lungs. You may notice, if you look carefully, a line there, so-called Hickman line, which is going in to the great veins of that patient and sitting into the superior vena cava. And from that line, blood can be drawn, taken out to measure the blood count, or to culture for the presence of bacteria, and also used to give chemotherapy or blood products. And you can see how much more humane this is for the treatment and how it helps to improve outlook. The cure rates for acute myeloid leukemia are not yet at the level of ALL, acute lymphoid leukemia in children, but certainly now over 50% in most cases. But the main challenge remains in the older age group. And the 5-year survival for people over the age of 65 with acute myeloid leukemia is less than 10%, even less than 8%. So that's an area where we need much more scientific advance and new clinical interventions. Welcome to this advanced lecture on the treatment of leukemia. The learning outcomes from this lecture will include the fact that leukemia represents around 8% of all malignant disease. There are 4 major subsets of leukemia, but there's great heterogeneity within each of these. The treatment of acute leukemia is highly effective in younger people, but it's very complex, and it's an area of unmet need in elder individuals. The treatment of chronic leukemia has shown dramatic improvement in recent years, and I'll look forward to telling you all about that during the lecture. Leukemia. The term means white blood. It reflects the fact that there are too many tumour cells within the bone marrow and the blood. On the right, you will see a blood slide from a patient with acute leukemia, and those cells are all abnormal tumour cells. The incidence of leukemia is relatively stable, and most subtypes of disease are seen in all societies around the world. The treatment of leukemia has changed dramatically in recent years, and I'd like to communicate some of that excitement to you during the course of this lecture. Let's start with acute leukemia. Acute leukemia develops from early hematopoietic progenitor cells. That means cells that give rise to the formed cells within the blood. And these cells proliferate too rapidly and don't differentiate into later cell types. This is an aggressive disease, and it can be rapidly progressive and indeed fatal within weeks if it's not treated. There are two subsets, lymphoid and myeloid disease, and acute lymphoblastic leukemia is the most common cancer or malignant disease in children. However, although it's a very aggressive disease, it can now be cured in many cases. On the right, you'll see some of these acute leukemia tumour cells. You'll see that they are large cells with a very large nuclear to cytoplasmic ratio. In contrast, chronic leukemia leads to the accumulation of blood cells which, under the microscope, look quite normal, mature blood cells. It's less aggressive than acute leukemia. The patient may carry this disease for many years before being diagnosed. Chronic myeloid leukemia, one of the major subtypes, is very, very important, not only in its own right, but because this was the first disorder for which a tyrosine kinase inhibitor was used highly effectively. The treatment for chronic leukemia is improving very significantly, but it's moving so quickly that we don't yet know how many of these patients will be cured in the long term. On the right, you'll see a picture of a patient with chronic myeloid leukemia. And there you will see there are many very primitive cells, but also some normal neutrophils. And it's the accumulation of these normal neutrophils that is characteristic of the blood film of a chronic leukemia. Lymphoid leukemia. The lineage of hematopoiesis, the formation of blood, can be divided into two major subsets. On the left of that diagram, you will see the myeloid lineage, and on the right, the lymphoid lineage. And these two lineages define the two major subsets of leukemia. So, lymphoid leukemia leads to the accumulation of lymphoblasts or mature lymphoid cells, and that represents 70% of all childhood malignancy. And as you'll see there, 85% or more of children can now be expected to be cured. In contrast, myeloid leukemia is on the left-hand side of that cell lineage. This includes neutrophils, monocytes, megakaryocytes, and red cell precursors. And the acute myeloid leukemia is seen in patients at all ages, although the outcome for older people remains very challenging. Indeed, acute disease is difficult to cure, even in younger patients, although we are improving our outcomes with intensive chemotherapy. Chronic myeloid leukemia, as we will see, is driven by the BCR-ABL fusion protein and is now highly treatable by simple tablet therapy.